breakthrough self-regulation interventions for children and adolescents with autism, ADHD, sensory, or emotional challenges. We are so happy to have you all here with us today. Before we jump in, I do want to go over a few housekeeping items for today. You'll notice on your screen there's a Q&A function. The Q&A function is for you to be able to ask any questions that you would like to the speaker throughout the day. We'll be getting to those questions after each break and answering as many as we can possible. The chat function you'll see on your screen as well. That's for you to interact with your speaker, interact with other colleagues on screen here, and just to share your thoughts throughout the day as well. So please use the chat function and also use the Q&A function as we work through the day. You'll notice that in your attendee portal, there's a live CE certificate column in your attendance portal for you to obtain your CE. That'll also be the place where you can go if you do want to purchase for the CE as well, if you have not already done so. Okay, now that I'm done with the housekeeping items, I want to welcome our amazing expert on this topic. Dr. Sheetal is an occupational therapist, certified autism spectrum disorder clinical specialist, and a certified yoga instructor. Dr. Sheetal is the founder and owner of Spot Therapy, LLC, a company that specializes in providing occupational and physical therapy services in schools. She has over 20 years of clinical experience working with children and adults in a variety of settings and with a variety of diagnoses, including autism spectrum disorder, sensory processing disorder, attention deficit hyperactivity disorder, developmental delays, genetic disorders, and more. She is a clinical assistant professor in the master's and doctorate occupational therapy programs at St. Joseph University in Philadelphia, PA, where she teaches in courses such as neuroscience, clinical skills, movement analysis, and so on. I'm happy to welcome Sheetal on the screen with us to go ahead and begin our session. Sheetal, welcome.
Thank you. Thank you, Evan and Maddie, for being here. And thank you to all of you who are attending this webinar. I am very excited to be here. Can you hear me? Okay.
We can hear you.
Can you hear me now? Okay. So I'm not sure if you were able to hear me earlier. Let me just come back here. All right, lots of thumbs up and hearts. Okay, so I'm going to try that again just in case, even though I feel like maybe you did hear me. So like Evan said, I wanted to say thank you, Evan and Maddie, and thank you to everyone who is here joining today. Like Evan mentioned, my name is Dr. Sheetal Parikh, and I am an occupational therapist. I have been for 23 years now, and I am a clinical assistant professor in the occupational therapy programs at St. Joseph's University in Philadelphia, Pennsylvania, like he mentioned. And I have been working in pediatrics and working with kids for the last 18 years. And I feel like working with self-regulation issues for, all of this time. And so I'm really excited to be bringing all of this content here to you. I know we have a really, really large group here today. I'm excited. And I do usually like to have people be able to share some information. And so if there are points where we can do that today, I would love to, because I always say, you all who attend my webinars are also experts. You have experience and you have tried things that work and things that don't work. And it's always nice to be able to share that and to learn from each other. So if we have those opportunities, we will try that today also. Just not sure with this really, really large group today. Okay, so with that being said, I do have, since you got to know a little bit about myself, I would like to get to know a little bit about you. So I see people are still popping in, and I want to say we have almost 9,000 people right, who have signed up for this course, which is amazing. But I'm going to start with some poll questions so I can get to know who is in my audience today. So Maddie is going to pop up those poll questions, and we're going to answer them one at a time. All right, so here's the first one. What is your profession or discipline? I always like to know who's in the audience, what great minds we have here together. Okay, we'll give you another few seconds to go ahead as we see those responses coming in. Okay, so, I still see responses coming in, but we have counselors, social workers. You are my largest population here today. Almost 35% of you are social workers, 30% are counselors, 5% are psychologists, occupational therapists, 15%, and then we have about 1% physical therapists, PTAs, okay, educators, 8%. Speech therapists, 3%, and others. Okay. And I always also like to say, you might wear multiple hats because you might also be a parent and a professional, or maybe you're just a parent who signed up. So I welcome all of you because you all bring your own special, clinical and discipline specific and parenting specific strengths and knowledge and expertise. So welcome everyone with that. And like I mentioned, I'm an occupational therapist. A lot of these interventions that we'll go through, I'll give you the disclosure in a minute, but it should be things that you or members of your team can work on together to try to implement. So just knowing your scope of practice will be important. Okay, so our next question here is going to be, what setting do you practice in? Just trying to get an idea. Are you school-based, inpatient, outpatient? Again, if you're a parent, you can, just mention that. So what setting do you practice in? Maddie, on that, I don't see the short answers coming up, so I'm not sure if you can just maybe shout out a few common ones you see.
It's not showing for me either, but I wonder if once I end it.
Okay, no worries.
All right, so it's not showing for everyone, but I'm able to take a look at it. We have people from school, early intervention, outpatient, pediatrics, school-based therapists, outpatient, home-based private practice, school and clinic-based, lots of pediatric hospital, outpatient mental health, residential. We got people joined from everywhere.
Okay, excellent. So we do have wide areas of practice that you're all practicing in. So that's great. I'm primarily, full-time professor, but I also do clinical practice or school-based practice and then early intervention. And I have done, the whole acute adult rehab, acute care, and all of that. So it's great to pull all of our areas of expertise here. All right, we have 2 more questions, so we'll move on to the next one here. How many years of experience do you have? I always like to gauge where we are in our learning process and how many years you've practiced. Okay. Give it just a few seconds here. Okay, so looks like I have more of my newer grads here as my largest percentage. 30% of you are from 0 to 5 years of experience. So welcome, lots of great information to learn throughout this webinar. And then we have, let's see, a good 25% who are 21 years plus. So we have all of this covered. We have a lot of seasoned veterans in the field, and then we have some newer folks. So excellent. Okay, great to know that. And then one last question. Geographically, what region are you from? Where do you live / practice? Probably primarily practice is what I want to know. Okay. Excellent. Okay, so I think most of these responses are coming in, and Eastern. All right, so a lot of my East Coast friends here, 38% of you, 25% of you are from the Midwest, 18% from the South, and 11% from the West Coast area. All right, excellent. So we are covered across the US here with all of you. So thank you so much for doing those poll questions. That really gives me a good idea of who is in the audience today, even though I can't see you and hear you. I feel you. Okay, so we are going to go ahead and get started. So the webinar is Breakthrough Self-Regulation Interventions for Kids with ASD, ADHD, Sensory, or Emotional Challenges. Now, I do want to just say, when we say breakthrough, it is not that it is one special, intervention or program. We don't have the magic wand, right? But breakthrough is using multiple different types of interventions and programs that you'll learn here that you've practiced and used in your own practice that have worked, pulling things together to really work with each kid. And because we know every child, right, is going to have a different set of interventions and treatment options and things that are going to work better for them versus the next child who might have the same diagnosis, but either presents very differently or might present somewhat the same way, but there's little things that, might work for one child that might not work for the other. So breakthrough is really looking at, being able to look at and, clinically reason what might be the interventions and approaches and techniques and programs that you want to try to implement in your clinical practice. Okay, so we will advance this slide. All right, so I just need to go over this. I have to read this notice here that materials that are included in this course may include interventions and modalities that are beyond the authorized practice of your own specific professional discipline. As a licensed professional, you are responsible for reviewing the scope of practice, including activities that are defined in law as beyond the boundaries of practice in accordance with and in compliance with your professional standards. So, if you're not sure, check back to your professional standards and your state regulations. And then a conflict of interest statement here that I must read is that as required by several accrediting boards, speaker and activity planning committee conflicts of interest, including financial relationships with ineligible organizations, were disclosed prior to the start of this activity. All right, so let's get into the content. So self-regulation, that's what we're talking about today. So before you even read the rest of the slide, if you want, close your eyes or kind of look away from the screen and think, if a parent asked you or a child asked you, what is self-regulation? How would you describe it? How would you answer that question? So just take a second here and kind of formulate your own definition or explanation of self-regulation. Okay, so in my research and with my doctoral students, I've really been focusing my research on self-regulation. And, one of the definitions that is pretty common is that it is the ability for someone to be able to regulate their thoughts, their emotions, and their behaviors in regards to a situation or a task, right? So self-regulation is the ability to manage and maintain multiple things within that, right? So we're looking at physical body function and movement, right? That's one of the components. Sensory processing. We are sensory beings and taking in sensory information every second of every day. How are we processing that to be able to stay self-regulated? Cognitive control, emotional control, and social interactions, right? And so we're going to go into those in more detail in the next slide. But knowing that self-regulation is sort of this umbrella term, and when we come upon a situation, we walk into a room or we're working with a child and they start to have, well, quote unquote, behaviors or a meltdown and they're dysregulated, we need to sort of step back and think, okay, what's going on and what components could it be? right? And so when we look at components of self-regulation, even in that physical component or that physical aspect, is it something that's somatic? Is it, movement related? Is it specific to things like eating and hunger or sleeping, that they didn't sleep well and they're feeling really dysregulated? Even with their speech output, the physical components of speech, are they having a hard time communicating because of the difficulties with speech articulation or oral motor, that now they can't get their needs met because someone can't understand them, and now they're feeling dysregulated, right, and upset and frustrated. And then also there's the autonomic response from the physical autonomic response, right? Do we, and I'll kind of flip back from we to the child, and I will use child, student, kid, kiddo synonymously, but does that child go into a fight or flight or freeze state physically? Or are they more relaxed? Is their body showing a physical calmness and relaxation, right? And these are all components of that physical aspect of self-regulation. Then we look at the sensory piece of self-regulation. So sensory is, it's this whole pathway, right? And so it's from receiving that information. How do we then process that information from our body, from our brain, in our brain? How do we then integrate it with the different parts of the brain, with the different experiences we've had? And then how do we modulate to be able to and respond to that sensory information, right? And then that could be that physical response of a fight or flight or freeze, right? It could be having that meltdown, it could be crying, it can be avoiding that sensory stimuli. So thinking about what's happening sensory wise during moments of, and usually when things are going well and we're feeling self-regulated, we don't really think about it. But when there's dysregulation, we really want to think about, like, okay, what is the sensory components? Is it really bright in here? Is it really loud for this child? Did something, some texture or somebody just rub against their arm and they didn't like that, right? So what are the sensory components that just happened? Or that are present in the situation. Then we want to think about the cognitive piece. Okay, is this child or a person have their executive functioning? Is it even developed yet? If they're young kids, right, that's not developed yet. Where are they cognitively in their ability to be able to focus, attend, make decisions? Can they plan what to do with that task or what to do when they're feeling dysregulated? The organization, the judgment, the higher level thinking. So all of those executive functioning skills that are, processed here in that our prefrontal cortex, right? And we'll get into some neuroscience in a little bit. So, and then we want to think about the emotional aspects or components of self-regulation. How is that child's mood? Are they in a good mood, or are they already coming into therapy or the classroom, or into your counseling session upset, or are they having negative thoughts, right? Where is their thought process? Are they in a little bit of a funk? Are they negative, or are they doing okay in terms of their thought process? Are they able to regulate their emotions? Can they process and understand that they're upset and then know what to do from there, right? So thinking about that. And then there's also the autonomic component of emotions, right? So our autonomic system, we have our sympathetic and our parasympathetic state, and our sympathetic state can rev us into feeling, or when we start to feel nervous or scared, our autonomic system kind of kicks in, right? And so it's being aware of, are they in a sympathetic state of regulation where they are, again, in that fight, flight, freeze is what's going on physically, but emotionally, nervousness, fear, anxiety can be going on. Or are they in a parasympathetic state where their nervous system is calm, they're cool, they're rest and digest, right? Feed and breed. So that's that parasympathetic state. And then we have the social piece of self-regulation, right? So we've thinking about what's going on physically with this child, what's going on sensory wise, what's going on cognitively, what's going on emotionally with this kiddo, and also socially, what's happening in the environment, what happened before. So positive interactions with peers and adults. Do they have the social skills for that? Can they understand social rules, and can they advocate for themselves? So there's a lot that we as clinicians, practitioners, and parents have to think about when we are thinking about helping our kids with self-regulation, okay? And then, we talk about self-regulation as professionals here and working with the people that we want to help, but we're also always going through self-regulation as adults. And so one of the big things is, I don't have a slide on it here for that, but it's really what we're doing is co-regulation. And it's how do we respond to situations to help our kids? So we need to look and check into our own self-regulation. Are we calm and collected so we can then help, right? Because we feed off of each other, right? We exist together, and we co-regulate every moment of the day. So if someone's in a good mood and smiles and waves at you and says good morning, you're more likely to feel that positive energy, right? If somebody comes into work and they're grumpy, or your kids are already having a bad day, they might make you, start to feed into that negativity. And so, of course, right, we feed off of each other. And so co-regulation is really what's happening here. So check this information. I'm going to play this video in a minute, but it's, it talks about kids, but we also, all of this information applies to us. And we want to check our self-reg skills, modulate ourselves to then be able to better help the kids that we serve. All right. And so also, I just want to give you a heads up that through the next handful of slides, there are 4 videos that I'll show. As a professor, I like to tap into different learning styles. So besides you just listening to me and looking at the text, I do have videos to help capture and sort of review the information that I go over. So I'm going to play this video here, which I really like because it does a great job about talking about self-regulation and what happens when kids have strong self-regulation skills and when they don't have strong self-regulation skills. So I'm going to go ahead and just switch over. Oh, didn't want to do that, but let's go. All right.
Successful people have strong self-regulation skills. They use them every day. The skills help them consciously direct, sustain, and shift their attention when necessary. They help them monitor and manage their thoughts, behavior, and emotions in this complicated world of ours. 3 of the self-regulation skills, known as executive function skills, are cognitive. These are used to monitor and manage attention, thoughts, and behavior. A 4th self-regulation skill is the ability to monitor and manage emotions. These skills are not inborn, but they are teachable. And we depend on them every day, especially when the going gets rough. Just like adults, when students are upset or angry, it's hard for them to use their executive function skills because their strong emotions take over. This can also make it difficult for them to listen, remember rules, and stay focused on learning. So, learning to monitor and manage emotions allows students to recognize their strong feelings and use strategies to calm down. Then, they can use their executive function skills again. And research shows students with strong self-regulation skills have higher academic achievement and are less likely to act in impulsive or aggressive ways, or to withdraw when overwhelmed. They're also more likely to get along well with others and have strong social skills. Students with poor self-regulation skills can have emotional and behavioral problems and academic trouble, and are more likely to be expelled from school, starting as early as preschool. When students learn and practice self-regulation skills, they can build academic achievement, social competence, and positive growth throughout their lives.
Okay, so I hope you enjoyed that video. And one of the, so we see, you know, when they have strong self-regulation skills, it impacts their academic skills, their social skills, their emotional regulation. So it's really, really important to understand and help our students and children to have and build self-regulation skills. And one of the things I like to mention here too is, you know, they talk about kids even getting expelled from preschool. So I actually did have a student like that who got kicked out of daycare because he had a really hard time with self-regulation, was getting very physical and aggressive with, you know, throwing things, you know, with other kids, with the adults at the daycare, and literally, you know, was expelled from the daycare. He came to our school for the preschool program, and I just love to tell a story because he's such a success. He's now going into 3rd grade. You know, I had him for occupational therapy services. He had some other services and an IEP, but he really learned self-regulation skills because he would get very upset, very frustrated, and, you know, did not know how to manage that. And so it was turning into physical aggression. And when he learned self-regulation skills, ways to calm down, take deep breaths, you know, deal and be able to know that, like, okay, I only have the choice of 2 things instead of always trying to get what he wanted. Working on a variety of different skills with him, he really succeeded, and he no longer has an IEP. He's doing so well academically, socially, has friends. Other kids want to play with him now. At recess, you know, he's right there amongst all the other kids playing with them, because before he would always want to control the situation, would always want to be the captain, or, you know, the one to pick, you know, and you guys know stories like that, right? Where the children always want to be in control. And so it's hard for them to make friends. And so that social piece is really, really important, because if they can't regulate themselves and their emotions and their behaviors, it starts to impact them. And later on, we'll see how that can, you know, just be a cycle of negativity also. So it is, you know, building self-regulation skills is possible, and we can see great success, especially if we're working together with, you know, we worked closely with his parents who were very involved. And so it really was a nice team effort to help him to succeed and no longer need an IEP for academics and for all of that social emotional learning. All right. So we're going to go over in the next, we kind of set the foundation here for self-regulation and co-regulation. And for the next handful of slides, I'm going to go over the 3 main diagnoses that we're going to talk about during this webinar, which is autism spectrum disorder, attention deficit hyperactivity disorder, and sensory processing disorder. So we're going to start with ASD. What is ASD, right? So I'm sure most of you who are here today work with students or people who might be on the spectrum, and or maybe you don't yet and you're interested in working with them, and so you're here to learn about it. So just to make sure, I know we have a variety of years of experience and settings, but just again, sort of make sure we're all on the same page, I'm going to just go over some information about it. So autism spectrum is a neurodevelopmental disorder. When we break that down, just understanding that it is neurological components and developmental components, right? And it is with ASD, typically in utero, while the brain is developing, certain parts of the brain and the connections do not form well. And in other parts of the brain, for some kids, it develops very well, right? And so we see those strengths and those limitations in function and behavior, right? So it is a neurodevelopmental disorder. It does affect, like I just mentioned, brain brain development, and then therefore those areas of the brain, the function that they have might not be as efficient or fully developed, and therefore then we see the deficits in their functional abilities. Okay, it does refer to a broad range of conditions, and typically if you've worked with ASD and you know, right, it's sort of three main components that they look at is those social skills, the repetitive behaviors and restricted interests, and then the speech and the communication piece of it, which is the speech and the verbal and nonverbal communication. So this picture here does a good job kind of giving you a visual of that. So we kind of think about like the three spheres or the three balls in this area, right? And so it's that social interaction, that they're not making that eye contact, that they like to play more by themselves, more independent, or I don't like to use the word loner, but sort of more, you know, to themselves, have a harder time socially interacting with others. And it's with peers and adults. Typically, they do a little better with adults because the adults sometimes fill in the gaps or will give them what they want or what they think the child needs, right? Where peers might not be able to read into that as well. And so it's a little bit harder for our kids with ASD with their peers than it is for with the adults in their lives. So that social interaction piece is one of it. Social communication is another, right? So it's that, again, that verbal and nonverbal communication, body language, reading into all of that. And then it's this social imagination and flexible thinking that they have difficulty with. So we know our kids with ASD, you know, the majority of them have that restricted interest, and they have that repetitive behaviors that they might engage in, whether it is the stereotypical behaviors of like rocking, flapping, stimming with fingers. Sometimes it's even the sounds and the noises and the echolalia that they might sort of perseverate on or repeat or fixate on. Okay, and when we have the combination of the three, it is that triad of the abnormal patterns of ASD. Now, I do just want to mention here too, having been in this field for a long time, you know, we do see the shift now too, that, you know, we've looked at what are the deficits and what are the difficulties that our kids are having, but we also really want to, you know, go with this shift in our mindset and to look at what are the strengths these kids have too. So, you know, now the research and the practice is moving at looking at strength-based practice, right, with our kids and adults with ASD. So I just want to mention that here, even though I might be focusing more on some of the, you know, the difficulties that we see, because I'm trying to help show interventions also. I do want you to know that there is a very strength-based approach that we can utilize with these kids. So even as we go through these interventions, I want you to think about what are the strengths of your kids? What are their deficits? What do we want to help them build? What are they already good at? And what can we also help them build and develop with? Okay. All right. When we look at the three functional levels of ASD, this is something that's also changed in the time that I've been practicing. Is so we used to say that kids are high functioning or low functioning, and now it is moved to the three functional levels of autism. And instead of just saying high functioning or low functioning, they are leveled by numbers. So kids who are ASD level 1, they are the ones who require the least amount of support, but they do require support. And without that support, they might have a harder time functioning and, you know, sort of optimizing and maximizing their abilities within situations and tasks. So they do require some support. These are our kids who might have difficulty initiating social interactions. And so they might need that adult support to help them to, you know, to start a conversation, or to even just say a greeting to help them get started with play with another peer. So it is the difficulty initiating social interactions, and these kids do have difficulty with organization and planning problems, which can hamper their independence. But with some support, they, can usually function well enough within, their classroom settings, within their social settings, and their home environment. And so, if we look at this picture here, this is our little kiddo who might be on ASD level 1. He's sitting there with the other kids, but, these kids here in the front on the circle rug are engaging in more cooperative play. He's here maybe in a little bit more parallel play. Okay. And so can be nearby, might have some of the similar objects and toys, but isn't really engaging yet and might need some support for that. Okay, then our ASD level 2, these kiddos require substantial support. Okay, and so they have social interactions that are limited. So this is where we see some of that restricted interest, repetitive behaviors that start to impact their functioning. And so they have, like it says here, frequent, restricted, repetitive behaviors that can impact their function. And then again, social interactions, they might need some substantial support to help to engage with peers and adults. And then our ASD level 3 is sort of our quote unquote lowest functioning level, right? So these kids or adults require very substantial support. So they have severe deficits in their verbal and nonverbal social communication skills, and they have great distress or difficulty changing actions or focus. They are much more rigid than our level 2 kids. So they have their restricted interests, repetitive behaviors might really impact their ability to engage and function well, right? And so they require substantial support. So this is the sort of newer version of the levels of autism. Okay, let's look at some prevalence for ASD. And I was just looking again last night to see if the stats have changed, and they haven't. So this is 2023, 2024, the CDC is reporting 1 in 36 children are diagnosed with ASD. And this surveillance, the survey is from a 2020 survey. So that is that 1 in 36 children are diagnosed with ASD. And when I was looking last night, when I started working with kids in 2006, the stat was 1 in 110. And as I've worked and as I've done presentations, every year that ratio, decreases, or the ratio increases in that, there are more and more kids who are getting diagnosed with ASD. So when we think about even classrooms, and I know you guys are in a wide geographic area, in our schools, typically our class sizes for our pre-K kids are about 10, 15 is what it maxes out at. So usually we have about 8 to 12 kids in our PSD classes, or not PSD, but in our preschool classes, and up to our, elementary schools. We're lucky to have smaller class sizes in the late teens, early 20s. But if you think about classes that might have 30 kids in them, 30, 35 kids, one kid in every classroom, could be diagnosed with ASD. So 1 in 36 kids, however you want to kind of wrap your head around that. What has not changed is that the diagnosis of male versus female has stayed pretty consistent through the years, and that boys are 4 times more likely to be diagnosed than girls. So again, something with male genetics, maybe that is making them more susceptible or, to having that diagnosis. So 4 in 1. And then we're going to talk about another factor in the next slide. Also, that could be a reason why girls maybe aren't diagnosed as much, but generally speaking, the stats is that boys are 4 times more likely to be diagnosed than girls. When we think about when are kids diagnosed, most children are diagnosed after the age of 4, though autism some sources say that autism can be reliably diagnosed as early as age 2. And as we even start to look at all of this artificial intelligence and ways that we can maybe have better screens and tools and assessments, maybe we might be able to diagnose them, more reliably as early, in even before 2. One of my own personal thoughts is always like, is this developmental or is this a true diagnosis of ASD? And I feel like in the earlier years, 0 to 3, 0 to 4, there's still a lot, 0 to 5, even there's still a lot of developmental progression that could be happening, right? And so sometimes trying to tease that out and seeing, is it just developmental gaps that are going to be closed with more experience and practice? Or is it truly a diagnosis of ASD or something else that might not allow that child to close the gaps in those developmental skills? So sometimes I personally do think waiting a little bit more, maybe until they are 3, 4, maybe even 5, sometimes if it's still really hard to tell, might be better. But I know that is, a personal choice, and especially with parents who know their kids best. If they see things that they just feel like aren't right, or kind of even like yellow flags, maybe not even quite red flags, it's definitely better to go to a developmental pediatrician, get it checked out, and see if they do meet the criteria. And sometimes, it might be a bit of a process, and maybe they are now another year or 2 older by the time everything is, they've gone through all of the doctor's visits and the assessments and all of that. But just to kind of come back to this, kids are typically diagnosed after age 4, and you can see the reasons why, but autism can be reliably diagnosed as early as age 2. Intellectual ability, right? This is so interesting. Our kids with ASD, again, it is a spectrum, and we do see that spectrum of cognitive abilities also. So 31% of children with ASD do have an intellectual disability that their IQ quotient is less than 70. So if we look at a standardized IQ test, and these kids take it, their scores fell below 70. 25% are in that borderline range, though, on a standardized IQ test, so 71 to 85. And look at this, the greatest percentage, 44%, have IQ scores in the average to above average range. So their IQ scores are greater than 85 on a standardized IQ test. And so this just shows you, I know there have been plenty of times I have said to my colleagues, to teachers, to parents, like, I know they're in there, and it's just, how do we get it out of them? How do we help them make those connections to be able to show us, what they know, what they can do. So always kind of go in again with that sort of strength-based approach, and knowing, really giving your child the benefit of the doubt. And because we see statistics, that show that 44% do have IQs in that average or above average range. All right. And, those are the kids too, if you're an older practitioner, that was what we used to call Asperger's, right? So before the DSM-5, in previous versions, there was it was separate, and Asperger's were our higher functioning kids and the kids who had probably the higher IQs, right? So, but now it's all under the umbrella of ASD. All right, so this video is a great video that really goes over ASD kind of from beginning to end in terms of the different signs, symptoms, interventions, things like that. So I'm going to play this video here for you to be able to kind of pull all this information in and process it. Let me try to do this new share. And
topic is autism spectrum disorder. Autism spectrum disorder is a range of neurodevelopmental disorders that involves delays in the development of many basic skills and functions, including the ability to socialize and to communicate. Autism spectrum disorder includes conditions such as autism, Asperger's syndrome, childhood disintegrative disorder, and an unspecified form of pervasive developmental disorder. The American Psychiatric Association reclassified pervasive developmental disorder to autism spectrum disorder. The name change came in 2013. Doctors don't use the term PDDs anymore. The condition begins early in childhood and lasts throughout a person's life. It causes problems with functioning in society. Autism spectrum is estimated to affect about 62.2 million globally as of 2015. Males are more often diagnosed than females. Causes. The exact cause of the condition is unknown. The research suggests that genes can act together with influences from the environment to affect a child's development in a way that brings about autism spectrum disorder. Some certain factors that may make a person be at a higher risk of developing autism spectrum disorder may include a family history of the condition, being male, having certain genetic conditions such as Down syndrome, Fragile X syndrome, and Rett syndrome, having older parents, extremely preterm babies. Babies born before 26 weeks of gestation may be at a greater risk. Other disorders, such as tuberous sclerosis. Symptoms. Symptoms usually are seen by the age of 2 years. Children with this condition can display a unique pattern of behavior and severity, ranging from mild to disabling. People with autism spectrum disorder generally have problems with social communication and interaction, and patterns of behavior. Social communication and interaction symptoms are having poor eye contact and a lack of facial expression, failing to or being slow to respond to someone, calling their names, resists cuddling and holding and seems to prefer playing alone, retreating into his or her own world, having difficulty with verbal communication, including problems using and understanding language, having difficulty with nonverbal communication, such as interpreting other people's gestures and facial expressions, having difficulty sleeping, having an aggressive behavior, difficulty expressing emotions or feelings and may be unaware of others' feelings, having an unusual tone of voice that may sound sing-song or robot-like. Patterns of behavior are usually limited and repetitive. They may include performs repetitive movements such as rocking, spinning, or hand flapping. Have an over-interest or fixating on an object or an activity. Performs activities that can cause self-harm, such as headbanging. Being more or less sensitive than others to sensory input, such as light, noise. Develops specific routine or rituals and becomes disturbed at the slightest change. Has food preference, such as eating only a few foods or refusing foods with a certain texture. Diagnosis. There is no specific medical test to diagnose the condition. To make a diagnosis, a specialist may recommend genetic testing to identify a genetic disorder, such as Fragile X syndrome, Down syndrome, or Rett syndrome. Observe the child and ask the parents or guardians how the child's social skills and behavior have developed and changed with time. Give the child tests that cover hearing, speech, language, developmental level, and behavioral issues. Use and follow the criteria written in the Diagnostic and Statistical Manual of Mental Disorders, or DSM, published by the American Psychological Association. Treatment. There is no cure for this disorder, but intensive, early treatment can make a big difference in the lives of many children. The goal of treatment is to improve the ability of the child to function by reducing symptoms and supporting development and learning. Treatment options include therapy, such as behavioral and communication therapy, educational therapy, family therapy, speech therapy, and occupational therapy. The type of therapy depends on the child's need. The core symptoms of autism cannot be improved with medications, although medications such as antidepressants can help to control anxiety or antipsychotics for severe behavioral problems. Thank you for watching our video, Autism Spectrum Disorder.
Okay, so I hope as you watched that, you were like, yes, that's familiar. Yes, I know that, or, yes, the kids I work with do have that, right? So if you have experience with kids with this, hopefully this was, a good review of that information. And, again, if you're new and you are just learning about ASD, these are the things you will see that, the kids have the difficulty with, emotions and understanding their own emotions and others' emotions. If someone else is upset, having a hard time understanding that, the social piece of it, even that sing-song voice or the monotone type of a voice. So a lot of these things. So this is a great video to give you a good idea of ASD. Okay, so I'm going to go ahead and we're going to move to, see if you can see. Okay, we're going to move on to ADHD and kind of go over this diagnosis. ADHD, attention deficit hyperactivity disorder. Again, before there was ADD, and now it is all ADHD. We see these are our kiddos who have difficulty with or who are hyperactive, disorganized, distracted, difficulty with attention and focus. They're forgetful. They have inhibition, difficulty with inhibiting, right? And we can see that, and I'll go over that, what physically and verbally, a lot of disinhibition. So let's get into ADHD. What is it? Again, if you wanted to sort of look away and think about how would you describe what ADHD or define it, right? Think about that for yourself. But when we ADHD, just like ASD, is also a neurodevelopmental disorder. So again, there's neurological components to it and developmental components to it. And it's, again, usually a child is born with ADHD. It just sort of might manifest a little bit later, but a lot of times those parts of the brain, when I say born with it, in the sense that those parts of the brain maybe didn't develop fully or make all those correct neural connections. And so we see the deficits that we see in them. And what are those deficits or difficulties these kids have? It is that persistent pattern of inattention and or hyperactivity, impulsivity that interferes with their functioning or development. So we'll talk about that here. So it's the three primary characteristics. Either they are, they have issues with inattention, right? So these are our kids who are the daydreamers, space cadets. You call their name 5 times, they still didn't even hear you or process it. And it's more likely they heard you, but their brain just didn't really attend to that, and process it like, hey, oh wait, that's my name. I got to do something. I got to respond. So it's the inattention piece. It is the hyperactivity piece. So they could have one or multiple of that, and we'll talk about that in a second. But our kids who are hyperactive, we know those kids, right? They are our movers, shakers on the go. They cannot sit still. They can't keep their hands still. You put things on the desk, they are touching everything. They are constantly up and out of their seats, walking around, running around, full of energy. They are our hyperactive kids. And then we have our kiddos who have impulsivity issues, right? So this is where they're uninhibited. And when we go over the neuroscience, right, it will make more sense to you, because we see what part of the brain is affected in ADHD. It's that prefrontal cortex. And that's where a lot of these skills are and functions are housed, right, and processed. And so these kids, they're impulsive. They're constantly moving, touching things. They're physically impulsive. And I also find these kids are very verbally impulsive. So always shouting out answers, before the question's even completed by the teacher or the adult. They butt into conversations because they don't wait for their peers or friends to finish talking, right? They're impulsive with their verbal output and their physical bodies. So when whoever can diagnose, the developmental pediatrician, the physician, the clinical psychologist or psychiatrist is diagnosing, the diagnosis will usually be written ADHD and then a category. So the child or adult could have inattentive type of ADHD, the hyperactive impulsivity type of ADHD, or the combined type, where they have some characteristics of the inattentive type and they have characteristics of the hyperactive impulsive type. And so then they are diagnosed with ADHD combined type. Now, the criteria is that you have to have 6 or more symptoms. And in this webinar, I don't have the symptoms listed here, but it is a whole, list of symptoms, and they have to show 6 or more of those in any of the categories to qualify for deficits in that category. And so then the other criteria is it's got to be 6 or more. It has to be that they show these in different settings. So not just that they're inattentive at school, but they've got great focus and attention at home and on the soccer field. It's got to be across different areas. So both at home, after school, in school, these symptoms have to persist across different areas, and that they were present before the age of 12 is what one of the criteria is. And if they're 16 or over, it's 6 or more. So what it basically, there's the whole criteria that the diagnosing professional would check off and see which category they fit best into. Okay. And then this video, I really like this video that goes over ADHD because it talks about it from a first person perspective. So it shows these, people, characters, but really from a first person perspective to appreciate it. So I'm going to play this video to help go over ADHD. Okay.
I took medication when I was a kid. Everyone said I would outgrow it, so I stopped taking the medication in college. Everything is so hard now.
I hate math. It's so boring. I know I'm bad at it, even though my teacher says I'm not.
I'm a failure. I can't remember to do homework. I lose things. I can't get anything right.
I hate feeling like I'm different, but I really am. Work seems like it's easy for everyone else.
These are the voices of people with attention deficit hyperactivity disorder, or ADHD. Millions of American children, teenagers, and adults experience this disorder, which makes it hard to concentrate, pay attention, organize, and focus. Their lives are complicated because of it. I know. One of these voices is mine. I was diagnosed with ADHD when I was 9. Most kids with ADHD start to struggle with symptoms even earlier than that. I first noticed my symptoms in school when we began doing projects that took planning, and I got frustrated a lot. Later in middle school, I was on the basketball team, but I was always late to practice. Eventually, my teacher called my parents to talk about my grades, since I understood the material, but didn't turn things in on time. At that point, my parents, my coach, and my teacher all compared how things were going. And that's when my parents took me to see my pediatrician. ADHD can show up in 3 different types: inattentive, hyperactive impulsive, and combined. My symptoms were more of the inattentive type. I was having a lot of trouble losing things or forgetting things, not finishing homework, and organizing my work for projects and future assignments. My parents told me at first that they wondered if I had a hearing problem, because sometimes I would look like I didn't hear them when they talked to me. Other children also struggle to keep their attention in class, can look super distracted at home and school, and have trouble with details for things they're not interested in. Kids with more hyperactive or impulsive symptoms have trouble waiting for their turn. They might get up from their seats in class, run around when it's not a good time to do that, talk all the time, interrupt people, or blurt out answers. A lot of times, kids with ADHD can get into trouble, since the symptoms can look like they don't care or aren't respectful of others. But they do care. They just can't control it because of their problem with attention. While some people might have inattentive type and others have hyperactive impulsive type ADHD, still others might have symptoms of both, which is called combined type. If people show 6 symptoms from either of the first 2 types, or a combination of them adding to 6, they fit the diagnosis. While ADHD is most commonly diagnosed in kids, almost all of them continue to experience it as teenagers, and a majority still have symptoms as adults. Only some people grow out of it. The most important thing to know is that treatment for ADHD works. For little kids, this is behavior therapy that also includes their parents, so the whole family can be part of the solution. For school-aged kids and older, the best choice is medication or a combination of medication and therapy. I had behavior therapy where I learned some skills, like specific time management and organization techniques, that helped me in school and in my sport. I also took a stimulant medication that helped me focus my attention. Sometimes people find great help in non-stimulant medications, especially younger kids. For most people, ADHD medications really help focus and block out distractions. ADHD is a serious challenge for kids, teenagers, and adults who struggle to pay attention and focus in many parts of their lives. But there is hope. Treatment works. School wasn't easy for me, but with my therapy and medication, I learned what I needed to do to make it work. People go on to do well in school and succeed in their lives and careers, in spite of and because of their ADHD. I know. I did.
I took medication when I was a kid.
Okay, so, and I love that last line there, that, because, in spite of and because of their ADHD, they were able to do well. So again, really finding the strengths of, sometimes if they are very, sorry, let me just come back here. So, hyperactive, how can we channel that to be functional and meaningful and effective for that child, right? So some of that impulsivity, how can we maybe try to, tame that down, but still be able to use that for, so kind of thinking about what might be best for them in terms of tasks at school, in terms of occupations as they get older, right? So really looking at some of those areas and trying to, because of and really helping them to maximize their functionality is going to be important. All right, so let's look at some facts to compare ADHD and autism, the two that we've talked about so far, the two diagnoses. When we look at population statistics, okay, I'm going to look at this national average here. One is in percentage. So the almost 10% of people are diagnosed with ADHD in the US. So that's the national average for the US, 9.8% diagnosed with ADHD. 2-to-1 ratio of boys to girls being diagnosed. So 2 boys to every girl are diagnosed with ADHD within that population. When we look at autism, it's 1 in 36, as I had mentioned in the previous slide. That's the national average currently. And again, that ratio of diagnosis is 4-to-1 for boys to girls. Okay, so boys are more likely to be diagnosed with both of these, ADHD and or autism. Okay, inherited, yes, there is a genetic component to both of these diagnoses, and because there is, their siblings are at a greater risk of a diagnosis if parents have it, and if one sibling has it already, again, because of the genetic factors. Heterogeneous, yes. It could be, it is not just homogeneous, it is heterogeneous in the in who can be diagnosed with it. When we look at the age of diagnosis, for ADHD, on average, around 3 years of age. Okay, statistics do show it is anywhere between 3 to 17. And even now into adulthood, people are getting diagnosed, but in general, around the age of age 3. And then for autism, like I had mentioned earlier, also around the age of age 2 is where they can start to be diagnosed more reliably, but 41% of kids do not get diagnosed until about age 3 or later. And one of the things there is that in terms of getting early intervention services, they might be missing out on that because early intervention typically is 0 to 3, depending on what state you practice in. But here in New Jersey, where I live and practice EI, it is 0 to 3. I know in Pennsylvania, EI is 0 to 5, but 0 to 3 is sort of a home, or and 3 to 5 is where they go into like intermediate units. But one of the drawbacks of not getting diagnosed until later is that you might miss out on the early intervention services. But on that, I do also like to mention that you don't have to have a diagnosis to receive early intervention services. At least I know not in New Jersey. And so if there are enough concerning factors that parents have, they can, talk to early intervention services, get assessed, and see if they qualify even without the diagnosis. So I always like to educate my parents and say, please be very aware, and, even keep a little journal of things that you see that you think might be areas of concern. Talk to your pediatrician about it. They might refer you to a developmental pediatrician, but take it from there and see if that you can, if the people involved on the team, the parents, the physicians, the other professionals think that, they would benefit from early intervention services, or at least the getting the evaluation, then you can definitely get, go through that process even without a diagnosis. And then in terms of symptoms, we know what sort of the typical symptoms are with these diagnoses. In terms of ADHD, it's the same for girls and boys, whereas in autism, it's a little bit different. And one of the reasons could be that girls do a better job at masking some of those symptoms, and or they have a little bit more higher social skills than the boys do, especially at those younger ages. And so again, they might be able to sort of mask or not sort of be a red flag with some of those symptoms that they might have. They might be milder, or the girls are just better able to sort of navigate through them. Okay. Underserviced groups. So underdiagnosis for girls, and this again comes back to a couple of reasons. Are the girls better at masking? Or are the girls, are some of the assessment tools that we have currently to diagnose not sensitive for our higher functioning or our level 1 girls, right? So again, they might get assessed and they might do okay on the assessment. And through those scores, they might not qualify. And so then they are not diagnosed. And so that could be one of the reasons for underdiagnosis, of why there's a greater prevalence of boys being diagnosed versus girls. So are there genetic factors that make the boys more likely to have ADHD? Or are we missing some of the girls because the assessment tools aren't as sensitive to capture that diagnosis and those symptoms? Or are the girls just able to sort of mask it at that point? So just sort of things to think about and be aware of, okay? Other underserviced groups are people in low socioeconomic areas. So they, and similarly, people living in rural areas. So some of the things are the access to service, the access to even getting an evaluation, right? So being able to see the specialists who can do an evaluation. And then even once they're diagnosed, sometimes the access to services are not available to them as readily, whether it's for geographic reasons, whether it's for financial reasons and socioeconomic reasons. And then one of the other things is too cultural barriers to diagnosis. There are certain cultures who might not be as educated on or as accepting of these diagnoses yet. And so they might not seek the evaluations and services. So this all affects outcomes, right, in terms of our statistics and also in terms of the services and the outcomes we see from that. Okay, and then we will go into our a third diagnosis or disorder that we're going to talk about is sensory processing disorder. Okay, so we're going to shift here, but you know what? Sensory really relates to both ASD and ADHD also. Okay, so what is sensory processing? Okay, sort of think about that for yourself, and how would you describe that or explain that? Just think. So I'm going to go ahead and go through that. Sensory processing is, again, a really, like I mentioned earlier, it's sort of like a pathway that we have to take and get from one point to the other. And how does all of that information, all of those steps work to have us be successful at processing and integrating and modulating that sensory input or sensory information, right? So we all go through sensory processing. We're all sensory beings. It is not just people with a diagnosis have sensory processing, right? We are all sensory processors every second of the day. Right now, wherever you are, sitting, standing, you are taking in information from the environment, the light, the sounds, the tactile of your clothes or the surface that you're sitting on, right? Any smells in the room. So we're constantly processing information all of the time, right? And even we have things that bug us, things that we might not like as much, might not be as comfortable, but we can tolerate that. Our neurological system can take it in, be like, oh, I don't really prefer that, but we can still get past it and function, right? People who have true sensory processing disorder, that input, that sensory stimuli is really impacting their function. They can't get past it. It is sort of just as prevalent the first second they got that input, 5 minutes later. So, we might hear a loud sound, turn to it, attend to it, which is very normal, right? And then we say, okay, that's just the landscapers outside mowing the lawn. So I'm going to focus on what I need to. But our folks with sensory processing disorder, that sound from that, tractor is just too loud and they cannot turn and focus on what they need to. And so that's when we have the difference between just sensory processing and the sensory processing disorder. Okay, so SPD is also a neurological disorder, okay, where somewhere along that path there is a breakdown. So either that information is not received properly. So an example is that, someone could touch my arm and could touch, somebody else's arm. How we receive that information could be very different, right? It could be the same amount of pressure, the same area of the arm that we're touched on, the same person who is touching us, right? But how we receive that information from those receptors on our skin through that neurological pathway, how it gets up to our brain and how we process it, because now we're not just taking in that stimuli, but now we're connecting it to past experiences that we have of being touched, or maybe the person that's touching us. So that information now gets factored in. How do we interpret that information? Do we say, okay, it's a safe touch versus this is a stranger, I don't know, and this is not a safe touch, right? And then how do we modulate our response? Are we going to pull our arm away slowly? Are we going to try to wave our arm and try to hit the person who touched us? So how do we modulate that response that we're going to have? Okay. And so when there's a breakdown in any of those steps or any aspect of that pathway, it leads to abnormal responses and behaviors. Okay. Now, this is something important to understand, because when we think of sensory processing and we think of sensory, we usually think of the environment and external, but sensory information can come from the environment and externally, which is absolutely true, but it can also come from within a person's body and their mind. Okay, so sometimes it's not noticeable to everyone because it's what that person is sensing internally, and we'll go into detail about that in a minute. And one of the other main things is to talk about here is that, right now, currently, SPD is not a standalone medical diagnosis in the DSM-5 or the ICD-10. So usually you probably wouldn't see someone coming in with a script or a diagnosis of just SPD because it's not identified yet in the DSM-5 or the ICD-10. There are researchers and advocates who are really working on trying to make it a independent diagnosis on its own. And so maybe in subsequent versions of these manuals, they will be. But for right now, we might see it with a diagnosis of ASD or ADHD, or maybe some other, genetic diagnoses or other diagnoses. Usually it's a co-diagnosis or a confounding factor. And so just some stats to throw out at you, that up to 90% of kids with autism have some level of sensory processing disorder, okay? And up to 60% of kids with ADHD have some level of sensory processing disorder. So it is very prevalent in the previous two diagnoses that we talked about. And we'll go over some statistics in a little bit about that too. Here's a short little video about sensory processing. Sorry, it's not wanting to click. Just 1 sec. All right, here we go. Sorry, folks, hold on. Getting there. I don't know why my screen. Okay, here we go.
1 in every 6 children experience sensory symptoms that interfere with everyday functioning. These symptoms are defined as either hypersensitivity or hyposensitivity to sensory stimuli. Hypersensitivity symptoms include extreme response to sudden high-pitched noises, fearful of surprise touch, avoiding hugs, poor balance. Hyposensitivity symptoms include constant need to touch people or textures, unintentionally harms other children or pets when playing, fidgeting, moving constantly. If your child struggles with sensory processing, brain balance can help. Call 800.
Okay, so that was just a quick little video, and I'll talk about a little bit of hypo and hyper responsivity and sensory seeking in subsequent slides. So let me just switch back here. Okay. All right. So we will get into that. But what you saw in that video, right? So they talk about the kids constantly fidgeting. And so some of the things we see are what we might see in kids with ADHD or what we might see in kids with ASD, right? So again, that's why we say there's that underlying some underlying sensory issues with a large, percentage of our kiddos with either of those other two diagnoses. All right, I'm going to just shift here and talk about levels of evidence and research. When we talk about evidence-based practice, we really want to think about a few things, right? Because I know, especially like in the field of occupational therapy, sometimes we don't have the best research to support some of the things that we might see anecdotally or clinically, right? And then we have other things that we are finding very good evidence for and evidence-based, interventions for. So, but when we work with these kids, right, like they say, if you know one kid with autism, you know one kid with autism, right? And even with our ADHD kids, SPD kids, there are things that could work, and sometimes there's things that show great evidence that still don't work for these kids. So let's just sort of talk about that here for the next few slides. So considering if you are looking into the research, right, you want to look at, are these studies, was it a large study with a large population or sample size, or was it a small study where that might have just had a few kids or a few participants in the study? Or was it even smaller and it ended up being a single case study where they really looked at one specific child or one specific case, right? Then you want to think about which are valid and to what extent, which ones can we trust and use in terms of the results that they got from those studies, and what results do we have to maybe be a little bit more cautious or think about a little bit deeper about whether we want to use that information, those interventions, and the information from those results in your own clinical practice, okay? So let's do a little thinking and analyzing here. A large study, you're looking at a large study for an intervention, okay, that had 2,000 children who participated in the study. The study was done very well. The methodology was great. The intervention process was great. They had good results, okay, for this specific intervention. And then a second and a third study were done that confirmed the results of the first study, okay? So a meta-analysis agreed and said that 80% of kids would benefit from this specific intervention, right? And we're just looking at an intervention in general here. So the question to you is, would you try this intervention? You read this study and you know this information now that, 80% of children benefit from this intervention. Will this intervention work for the child you see that has similar or the same symptoms? Okay, so kind of just think about that. And what do you think yourself? And I'm going to just check here something. All right. All right. All right. So I see your thumbs up. Okay. So it seems like you would be. Okay. All right. So you think this is a good thing. We should try this intervention. 3 studies, a huge, large sample population of 2,000 kids, even just in that one study. We don't know how many were in the second and third, right? So this looks like something, yes, as, educated practitioners, you would think this is good. I'm going to try this with my kiddo or my client, right? Which makes sense. Okay. But also knowing it's 80%, and even if it was 90%, again, it might not work for your child, but this is something that shows good evidence that is probably worth trying the intervention for someone who has same symptoms. Okay. Then we're going to look at, on the flip side, let's say that you looked at a study that was looking at weighted vests. This study had 8 children in it, so a much smaller sample size, right? And then it went to individual single cases. So then they had to look at each kid in a single case study because there wasn't even enough correlation between the 8 kids there. There was a strict protocol. Okay, 2 children benefited from wearing the weighted vest. one child seemed to benefit, but the results were inconclusive. And the other 5 children did not show good results in terms of the benefits of wearing a weighted vest. So the question is, will this intervention work for the child you see who has the same symptoms? So if you know just this information, give me a thumbs up if you would try a weighted vest with your child who has same symptoms. Okay, so I see a lot of thumbs up. Okay, and so for anyone who has tried the weighted vests on their own clients or kids, especially my OTs out there, right? You might know that definitely there's not good evidence for weighted vests, but is it just that the studies we weren't able to actually collect enough, data and evidence for this? So again, I have tried weighted vests with my kids, with my students, and for some of them, it works well. For some of them, it worked well over a good long period of time. Not that they're wearing it for a long period of time, but as an intervention tool. For some of them, it worked, but that only lasted for a couple of weeks, and then they no longer liked wearing it or didn't have an interest, or it wasn't having the same effect. And for some of my kids that I've tried it with, they don't even like to put it, you put it on and they're fighting to take it off right away, right? And so it is really, this is one of those that maybe you should try it and then see. But again, this is where it's important to take documentation to say what times of the day are they wearing it, for how long, right? And we know, those of you who know weighted vests, like usually it's about 20 minutes on, 20 minutes off. You don't want to leave it on for prolonged periods of time because the nervous system sort of acclimates to that, and then it doesn't have the effect, the weight doesn't have that same effect for that child anymore. So that's why we take it off for a period of time and then reintroduce it again when that neurological system can be reset. And so, I always feel that it's worth trying different interventions if of course, safety considerations and all of that. And then trying to see, because every child is different. Okay. And then again, going back to that documentation, just trying to find the patterns of why it might be working or not working for that child. What's going on in the environment? What is the task that child has to do at that time when they're wearing the vest? Maybe what is their, mood or their emotional state at that time. If they're already really upset and frustrated and you try to put the vest on, it might not have the same effect as if they might be a little bit calmer in the sense of accepting that vest, and then it can do, the job to help to calm them to be able to focus. So, here's something to think about too. ADHD studies, if we looked at things that have non-homogeneous groups, right, then we can see why we might get different results. So if the study was done, but they looked at kids with different age groups, right now we already have too many factors of different age groups. If you look at different ADHD subtypes, we might get different results if we look at the subtype of just the inattentive type of ADHD versus kids who have the hyperactive impulsive subtype, right? So that could be a factor that could contribute to why an intervention might not be working. Mixed population with respect to medications. If we look at studies where some kids are on meds and some kids are not on meds, and then they're trying the same intervention, some other kind of intervention, we might have different results because the medications can be a factor. Okay, so where it matters when we look at results that say why things didn't work, we want to look back and see, how controlled were the groups. And then some of the things that are new and promising are in research is the neuroimaging and the artificial intelligence that, I'm actually currently taking a course on artificial intelligence for professors, and it's just so interesting. And to, I mean, it's AI is here and it's all around us and we are all pretty much using it at some level. But what we can do with it, you know, of course, with the ethics and all of that in mind, I think is going to just be so, you know, is going to be a huge factor and bring about so much change, hopefully for the positive in terms of our clinical practice and our academic practice. So neuroimaging and other advances in science and technology are going to really help us. Okay, so let me see here. It's 10:30 and we're at this point here. I think what we'll do is take our 15-minute break here before I get into the nervous system. So we will stop for our morning break here. It is 10:30 Eastern Standard Time. So we will pause for a 15-minute break and we'll resume at 10:45 Eastern Standard